Good morning, everybody. My name is Brooke Phillips. I'm the Marketing Manager for Shield Healthcare, and I'd like to welcome you to today's webinar on best practices, evidence-based guidelines for preventing catheter-associated urinary tract infections. Before we begin today, just a few housekeeping items. Attendees will be in listen-only mode, so if you have a question, please type it in the question box on the right-hand side of your screen, and we'll try to address as many questions as we can at the end of the presentation. A PDF of the presentation slides is also available for download right from the webinar. If you registered as a healthcare professional and would like to receive CE credit, look for an email from Capital Nursing Education containing your CE certificate within 5 to 7 business days. If you're watching this presentation as part of a group, please download the group CE handouts from the webinar panel in order for everyone in your group to qualify for CE credit. If you miss any portion of this presentation or would like to share it with a friend or colleague, the webinar is being recorded and it will be available on shieldhealthcare.com/webinars by the end of the week. I'm delighted to introduce Kelly Sparks, RN, BSN, CWOCN, as our presenter today from Capital Nursing Education. Kelly has been a CWOCN for more than 25 years and a nurse for more than 30. She's worked in wound, ostomy, and continence care for most of her career. Kelly has been on the board of directors for the Pacific Coast region several times in the past and on multiple projects for the WOCN Certification Board. She's active with the local Sacramento WOC nurse group where she serves as secretary. She's recently retired from Dignity Health, but continues with her private practice. Kelly has been a speaker for many different conferences and classes. She enjoys speaking for Shield Healthcare webinars and working with Capital Nursing Education to help promote education necessary for the care of patients. At this time, I'd like to pass the presentation over to Kelly. Kelly, it's all yours.
Thank you, Brooke. So we're going to look at this best practice evidence-based guidelines, which is very important for preventing catheter-associated urinary tract infections, or CAUTI as we call it. So the objectives, the first thing is we really need to understand what best practice evidence-based practice means, and also to review the causes and symptoms of catheter-associated urinary tract infections. We need to look at the indications for indwelling urinary catheters and explore basic methods of CAUTI prevention in patients with neurological diagnoses such as spinal cord injuries, spina bifida, multiple sclerosis, and cerebral palsy. So I want you to please note here that the literature, and I looked at a lot of it, it generally reports on catheter-associated asymptomatic bacteriuria, which is CAASB, or CA bacteriuria. It's used when, that name is used when no distinction is made between CAASB or CAUTI. In some cases, predominantly CAASB rather than on catheter-associated urinary tract infection. Most recommendations in the guidelines that I found refer to CA bacteria. So just so you know that is interesting in the literature. Looking at evidence-based practice, most nurses have heard of evidence-based practice. It's very important. It's the integration of clinical expertise, patient values, and the best research evidence available into the decision-making for the process for the patient care. It also, there's several different, you can see here several different examples, such as it means integrating individual clinical expertise with the best available external clinical evidence from systematic research. It's all about the research. So, and then evidence-based practice is an interdisciplinary approach to clinical practice, and it's been gaining ground following its formal introduction in 1992. So a lot of people are aware of evidence-based practice, and it's very important for our hospitals and for our long-term care. Let's look at some facts. So the most effective way, and most of you probably know this, the most effective way to reduce the incidence of catheter-associated infection, either ASB, bacteria, or CAUTI, is to, number one, reduce the use of urinary catheterization, and number two, restrict its use to patients who have clear indications, and remove it as soon as it's no longer needed. A lot of times we see them left in too long, way too long. Out of the 80% of hospital-acquired infections 80% of those are associated with urinary catheterization. And 12 to 16% of the hospitalized patients receive indwelling catheters during their hospital stay. And incidentally, the 3 to 7% increase of risk daily as the patient stays in ICU. So that it really makes a huge difference if we get those catheters out as soon as possible. It is estimated that each year more than 13,000 deaths are associated with UTIs. So catheters should only be used for appropriate indications and should be removed as soon as it's no longer needed. More facts on this is that the rates are on the rise, and you would think that they would not be on the rise because we've been teaching for a long time to remove those catheters as soon as you can. But CAUTI is the most commonly reported hospital-acquired infection, and more than 560,000 patients develop CAUTIs each year. 70%, they're preventable, which means that 380,000 fewer infections could be prevented and 9,000 fewer deaths if they use the prevention. So those facts are pretty interesting, and it is, in the literature. And that is not the one I wanted. Sorry about that. Diagnosing catheter-associated asymptomatic bacteriuria and catheter-associated urinary tract infections, signs and symptoms of UTI with no other identified source of infection. So we got to rule out any other source of infection, along with over 10 to the third colony-forming units of more than one bacterial species in a single catheter urine specimen or midstream voided specimen from a patient whose urethral, suprapubic, or condom catheter has been removed within the previous 48 hours. That's a lot to diagnose a catheter-associated asymptomatic or a CAUTI. So the signs and symptoms of CAUTI, it's basically, you all probably know this, but cloudy urine, blood in the urine, strong odor of the urine, leakage around the catheter, which would indicate that they're having these detrusor contractions that can cause that leakage, vomiting, unexplained fatigue, dysuria, suprapubic tenderness they may complain of, confusion in elderly. That's the first thing when somebody comes into the ER and they're elderly and they don't see any other reason why they're confused and it's new confusion, check that urine because they don't show any other symptoms basically besides that confusion. Some causes. We have all seen, I've seen, and I'm sure you have, if you are a nurse, you've seen nurses that allow the drainage bag to sit on the floor. I've seen it everywhere. And also people cleaning up stool and raking it right across the meatus. That can cause infection as well. I've seen them lay the bag, when we're going to reposition a patient and laying the catheter bag on their knees and it's higher than the bladder and then that urine flows back into the bladder. That can cause infection. And we've all seen the bulging drainage bag where it gets forgotten and not emptied, which means that bladder's probably bulging and has a lot of urine just sitting in there. Or the nurse who placed the catheter without cleaning the meatus well enough and allows the tip to touch the thigh or anywhere and introducing some bacteria that way. So there's a lot of ways that CAUTIs can be caused, and we need to look at how to keep from doing all of those. So there's appropriate indications for indwelling urethral catheter according to the Centers of Disease Control. So the CDC set up a very nice website that is www.cdc.gov and then /infection control /guidelines /CAUTI. That's going to be in your references. Healthcare Infection Control Practices Advisory Committee worked on this, and they worked very hard to come up with the following guidelines for prevention of catheter-associated urinary tract infections. So According to them, acute urinary retention or bladder outlet obstruction is an appropriate indication for an indwelling catheter, along with the need for accurate measurements of urinary output. For instance, perioperative use for selected surgical procedures. If they're going to be doing any genital urinary tract surgery, they're going to want to have that catheter in. If they're anticipating a prolonged surgery, it should then be removed in the PACU. Intraoperative monitoring is sometimes very, very important, so they'll need a catheter for that. And large volume infusions or diuretics during surgery are going to be a good indication that you need to have that catheter. A stage 3 or 4 sacral or perineal wounds in incontinent patients certainly need to have a catheter in order to treat those wounds and help them to heal. To improve the comfort for end-of-life care if needed. Sometimes that happens. I haven't seen it too often. Prolonged immobilization, potentially unstable thoracic or lumbar spine, multiple traumatic injuries such as pelvic fractures. They're going to need to have a catheter. These are the appropriate indications for indwelling catheters according to the CDC. So inappropriate uses would be, a substitute for nursing care. We've all seen that, of the patient or resident with incontinence. Obtaining urine for a culture or other diagnostic tests when they can void. Why cap them if they can voluntarily void? Used for prolonged post-operative duration without appropriate indication. So if they put it in for that surgery, PACU nurses need to get it out as soon as possible. Okay, so there are some good alternatives to indwelling urinary catheters, and we're going to look at some of those. Consider using external catheters in cooperative male patients without urinary retention or bladder outlet obstruction. That is also, I failed to put this in here, for the females, there's the one that sets up to suction that is actually a wicking device. That works very well if they're not confused, and we talked about that in another session. Consider intermittent catheterization in spinal cord injury patients rather than putting in IUC. Intermittent catheterization is preferable to indwelling catheter or suprapubic in patients with bladder emptying dysfunction. You want to consider intermittent catheterization in children, especially if they have a neurogenic bladder. You want to reduce the risk of urinary tract deterioration, which can happen when they have a catheter in long term. So best practice for the indwelling catheter. And we're going to go through what is the best practice according to CDC. So the first thing is, again, place it only when it's necessary. You want to look at your patient and determine if they meet these guidelines before you put a catheter in. So it also has to be inserted by a trained person using sterile technique. I have not seen it done by somebody who wasn't trained, but I'm sure that it has. Clean around the meatus very well. Use an 18 French or larger. That can increase the erosion, so you want to use the smallest that you could use. 30 cc balloons are not recommended. We all feel like, I'm going to put more in there because it's leaking around it. Well, the thing about that is if you put 30 cc's in, that makes a very large balloon, and that makes the tip of the catheter not even able to get the urine at the base of the bladder, first of all. Secondly, it irritates the inside of the bladder, causing detrusor contractions, which then causes more leakage. So it's very important not to put 30 cc's in the balloon. Consider other methods to drain the urine, such as the external catheters for men and for women, and the intermittent urethral catheterization. Very important not to irritate that bladder. Okay, indwelling urinary catheter placement. This is all kind of, review for those of you that have been doing it a long time, but there's a streamlined, evidence-based RN tool that is put out, and it's for the Catheter-Associated Urinary Tract infection prevention. So prior to insertion, you're going to first look and see if they're appropriate per the CDC guidelines. Second, use the smallest appropriate catheter. Third, 14 French 5 ml or 10 ml balloons. Obtain assistance, PRN, and that is important because that keeps you from getting that catheter bumping against things you don't want to bump against while you're putting it in the meatus. And perform hand hygiene. So does the patient meet the CDC criteria? We've looked at that, so let's say no, our patient doesn't meet it, okay? So you're not going to insert it. You're going to assess the urination and bladder emptying. So then we go down to the patient has urinary incontinence? Yes. So if your patient does not meet the guidelines by the CDC for putting in an IUC and they have urinary incontinence, you're going to develop an individualized toileting plan with interdisciplinary input, such as your prompted voiding, use of a commode, use of an anatomy-appropriate urinal to regain their continence. Use anatomy-appropriate collection device, such as external catheter, penile pouch, sheath for the male, urinary pouch maybe for the female, or the absorbent product to manage incontinence and maintain skin integrity. Then you're going to assess their bladder emptying and make sure they're emptying all the way. Now let's go back up. They do not meet the criteria, and the patient has urinary incontinence? No. So then you look at, has the patient urinated? And if they have, then you're going to assess their bladder emptying, make sure they're emptying all the way. If they have not, you're going to prompt them to urinate and evaluate the results. So that's for the no side. For the yes side, if you can, insert that according to the CDC criteria, we're going to look at a checklist that we'll go through in just a minute. But you want to assess them daily for meeting that criteria. Follow nurse-driven removal protocol if approved by the facility. You want to prevent CAUTI after insertion, and we'll go through that as well. Assess for and report signs or symptoms of CAUTI. And then, do they meet the CDC criteria for it? No. Then you remove it, assess the bladder emptying, and if it's yes, then you prevent CAUTI. So this is a really good algorithm that is also in the references that you can find, and it really makes sense. So now the tools checklist, we're going to assess for adequate bladder emptying. If they've voided within 4 to 6 hours, then you follow these guidelines, where you're going to have a look and see if they have a minimum urinated volume of less than 180 in 4 to 6 hours, or urinary incontinence present. Confirm their bladder emptying. You must make sure they're emptying all the way. Prompt the patient to urinate. Check for spontaneous urination within 2 hours. And if their post-void residual is less than 300 to 500, you need to recheck that in 2 hours. Perform straight catheterization for a post-void residual per scan that is more than 300 to 500 ml. Then you're going to repeat that every 4 to 6 hours and determine the need for straight catheterization, and report to provider if retention persists over 300 to 500. Perform ongoing straight catheterization per facility protocol to prevent bladder overdistension or renal dysfunction. And CDC indicates that, and then usually it's over 4 to 6 hours. But then if they've urinated more than 180 ml in 4 to 6 hours, that is adequate bladder emptying. So you would use an individual plan to promote and maintain normal urination pattern. So B says if the patient has not urinated within 4 to 6 hours or complains of bladder fullness, then you still need to determine the presence of incomplete bladder emptying. Prompt them to void. If the urination volume is less than 180, use your bladder scan. And you want to know if what their post-void residual is. That's very, very important. And if there's no scanner available, straight cath them. You need to know that. On the form from ANA, it then has a checklist to follow for insertion and maintenance of the catheter. We're going to go over a little bit of that as well. So the proper techniques for urinary catheterization, again, just to go over this: perform hand hygiene, perform pericare, re-perform hand hygiene, maintain strict aseptic technique, re-perform hand hygiene upon completion, and insert catheter to the appropriate length, and then check the urine flow before you do the balloon inflation. And then, of course, don't inflate that balloon higher than 5 to 10 cc. So then, again, per CDC guidelines, number 1, of course, hand hygiene. Number 2, ensure that only properly trained persons, we went over this, make sure they know how to do it. And in the acute hospital, we're going to use aseptic technique with sterile equipment, which I think we do that also in home health. Then we're going to look at the proper techniques for the catheter insertion per the guidelines. In the non-acute care setting, clean technique for intermittent catheterization is acceptable, and it's more practical than sterile technique, especially since nothing in the home is sterile. So we just definitely will use the clean technique. Properly secure the indwelling catheter after insertion. We went over this in a different class about how important it is to keep it from irritating the meatus and just to keep it from falling out if it can. But you want to properly secure it so that it doesn't have any pressure on it. Unless otherwise clinically indicated, use the smallest bore catheter possible. If intermittent catheterization is used, you want to perform it at regular intervals to prevent overdistension. And again, consider using a portable ultrasound. That's to assess the urine volume in patients undergoing intermittent catheterization so that you can determine how often they need it and whether it's getting emptied all the way. Ensure that the indications are clearly stated when you use it, and the nursing staff are trained to use it, and of course clean and disinfect the equipment after the patient, each patient. ANA came up with this really fine-tuned indwelling catheter placement management. After insertion, perform triple action for IUC drainage system. Number 1, yes, secure it. 2, position that bag below the bladder, not on the floor, and check the system for closed connections, and ensure no obstructions and no kinks. Maintain a closed drainage system. If it breaks, if there is a break in aseptic technique, if there's a disconnection or leakage occurring, replace the catheter and the collection system. Consider using pre-connected sealed catheter tubing junctions and maintain an unobstructed urinary flow and avoid twisting or kinking the tube. Keep the collection bag, again, below the level of the bladder, and don't rest the bag on the floor. Empty the collecting bag regularly and prevent the drainage spigot from non-sterile collecting container. I've seen that a lot too when somebody goes to empty it and they open up the spigot and then they hit it on the sides of the container, and that just makes me shiver. And then I have to tell them, we need to replace it. Unless clinical indications exist, such as bacteriuria post-urologic surgery, do not use systemic antimicrobials routinely to prevent CAUTI. Do not clean the periurethral area with antiseptics to prevent CAUTI while the catheter is in place. Routine hygiene, cleansing that with good old soap and water, is appropriate in bathing or showering. Unless obstruction is anticipated, bladder irrigation is not recommended. That can really introduce some bacteria. Using standard precautions during any manipulation is very important of that collection system. And changing the catheters and the bags at regular intervals, you don't want to, changing indwelling catheters or drainage bags at routine fixed intervals is not recommended. And the reason is it's not always necessary. You want to change them when there's clinical indications such as infection, obstruction, or when the closed system is compromised. Unless clinical indications exist, such as patients with bacteriuria upon clinical or catheter removal post-urologic surgery. You do not want to use systemic antimicrobials routinely to prevent CAUTI in patients requiring either short or long-term catheterization. If obstruction is anticipated, you need to, the close continuous irrigation is suggested, and that definitely helps the patient. Routine irrigation with antimicrobials is not recommended. Routine installation of antiseptic or antimicrobial solutions into the urinary drainage bag is not recommended. And clamping indwelling catheters prior to removal is not necessary, which is new to some people. If obstruction occurs, it's likely that it's because of the catheter material that's contributing to the obstruction, so you need to change the catheter. You know, those of you that are looking for ways to improve your resume or just to improve the care of these people, further research is needed. If you need to do some research and get you know, some articles out there, it's really, really important that we all look at this, because further research you'll see throughout this whole thing is needed in a lot of different areas, especially in the benefit of irrigating the catheter with acidifying solutions or use oral urate inhibitors in long-term catheter patients who have frequent catheter obstruction. There is no recommendation for this, and it is an unresolved issue. So again, that's a good opportunity for some research to be done. Further research is also needed on the use of portable ultrasound device to evaluate the obstruction in patients with indwelling catheters and low urinary output. So again, write some articles, get published. That's great for your resume, as well as for your nursing process that you're doing. Further research is needed on the use of methamphetamine to prevent incrustation in patients requiring chronic indwelling catheters. And these are ones that are high risk for obstruction. There's no recommendation. It is an unresolved issue, so let's get out there and resolve that issue. If the CAUTI rate is not decreased in your facility after implementing a comprehensive strategy, consider using some antimicrobial or antiseptic impregnated catheters. The comprehensive strategy should include the high priority recommendations for urinary catheter use, aseptic insertion, and maintenance. Hydrophilic catheters might be preferable to standard catheters for patients requiring intermittent catheterization. Silicone catheters might be preferred for reducing the incrustation in long-term catheterized patients who have frequent obstruction. These are all per the ANA guidelines. So that's why I'm reading each slide, because I don't want to change what it says there. Education and training. Periodic in-service training, we all know that. We need to do that regarding techniques and procedures for urinary catheter insertion, maintenance, and removal. Provide education about CAUTI, other complications of urinary catheterization, and alternatives to indwelling catheters. Consider providing performance feedback to personnel on what proportion of catheters they have placed meet facility-based criteria and other aspects related to catheter care and maintenance. And then with the home care, each RN should teach the patient proper methods, of course, of cleaning the catheter, changing the drainage bag, caring for the leg bag, caring for the night bag, cleaning the drainage bags, and preventing infection. Those are what we need to teach every single patient that has a catheter at home. Teach patient to call the doctor or the nurse immediately if they have any of these things. A temperature over 101, and please, if it comes out, do not try to put it back in yourself. I've had some patients who've done that. If you're making less urine than usual, that could be an indication of something's going wrong. If you have foul-smelling urine, bright red blood, or large blood clots in the urine, have abdominal pain and no urine in your catheter bag, you need to call for help immediately. And that doesn't mean wait for a few hours and see if it resolves itself. Using clean intermittent catheterization in the non-acute care setting, it's acceptable to use the clean technique. And this is more practical alternative to sterile technique for patients requiring chronic intermittent catheterization. Further research, again, is needed on optimal cleaning and storage methods for catheters used for clean intermittent catheterization. And if intermittent catheterization is used, you want to perform it at regular intervals to prevent bladder overdistension. That's very important as well. So some considerations: portable ultrasound device to assess the volume left in the bladder, reduce unnecessary catheter insertions. You may not need it every 4 hours or every 3 hours or whatever you've been doing. If the ultrasound bladder scanners are used, ensure indications are clearly stated, and the nursing staff is trained, and equipment, again, is cleaned between patients. So let's look at bladder management in the context of atypical neurological function. This includes most diagnoses affecting neurological function, including spinal cord injury, Parkinson's, multiple sclerosis, muscular dystrophy, stroke, neurogenic bladder, neurogenic lower urinary tract dysfunction. One example, bladder management in the context of spinal cord injury. These dysfunctions result in the following symptoms. They're going to have urgency, increased daytime and nighttime frequency, urinary retention, and UTIs. Frequent UTI in the SCI population is 3 or more UTIs per year. Intermittent catheterization is the gold standard for treating neurogenic bladders. Clean intermittent catheterization contributed to increased life expectancy of people with spinal cord injury. UTIs with spinal cord injury population, it's a little different than what would be considered normal patient. UTI protocols for treatment and follow-up are different with the neurogenic bladder because they have decreased pain sensation and other potential sources of infection. So you want to look for those things. Asymptomatic bacteriuria is not a disease. Presence of bacteria in the urine is not unusual with CIC users. And it may be a sign of poor hydration or infrequent catheterization, and it can be addressed by changing their hydration and bladder management routine. But it's certainly not uncommon for them to have bacteria in their urine. So when do we treat them? So the treatable level of infection in SCI patients, these are all the symptoms that you would expect. Fever, rigors, altered mental status, malaise, all of these, increased incontinence, increased frequency of catheterization or voiding, increased spasticity, autonomic dysreflexia, and just a sense of unease. You want to look at those and make sure that they're not having an infection. So colonization, 60% of individuals that are using CIC are chronically colonized. Without the physical symptoms accompanying positive UAs, they're considered asymptomatic and are not candidates for antibiotics. Bacteriuria and pyuria are important in diagnosing when symptoms are present. Treatment in this population are antibiotics. They're used with a positive urine culture and sensitivity and presence of the clinical symptoms. Treatment of asymptomatic colonization with antibiotics does not benefit the patient whatsoever, except in patients with urea-splitting bacteria such as protease, which can help to prevent bladder calculi. So it's important that we don't treat these asymptomatic colonization unless they do have symptoms of or protease. Which antibiotics should be considered? Good old ciprofloxacin, okay, 3 to 7 day treatment regimen. In clinical practice, a 7-day course is used due to the complex and recurrent nature of UTI in those with neurogenic lower urinary tract dysfunction. And if they have allergies to that, then you can use cephalosporins, nitrofurantoin. Complex UTIs may need some different antibiotics, may need IV antibiotics. Occasionally, intermittent bladder irrigation with neomycin and polymyxin has been used, but evidence to support this, again, is weak. Diagnosis and complications of CAUTI. Of course, you're going to do a urinalysis first, and then a urine culture if needed. If untreated, these complications of CAUTI would be kidney infection. May cause further immune system stress, making patient more vulnerable to future infections. So it's very important. The complications are huge. Current treatment for recurring bladder infections in individuals with a neurogenic bladder, good old cranberry. Cranberry, vitamin C, oral antibiotics, and other medications as indicated. Anticholinergic medications, Detrol, and such. You want to there's a lot of different treatments. Sterile pre-lube hydrophilic catheters that are self-contained. Close the catheter system is what I was trying to say. And an indwelling Foley catheter. But these are treatments for the recurring, has to be recurring bladder infections with neurogenic bladders. Current treatment for recurring bladder infections in neurogenic bladders, there is the Mitrofanoff procedure that can be done, bladder augmentation can be done, ileal conduit urinary diversion or cystectomy. These things are when they are recurring over and over and over, and that can be very hard on their body and cause a lot of different problems. So these are the 4 things that they would look at if they are seriously recurring. Persistent UTIs, over 500 ml bladder volumes, you can adjust the fluid intake and the frequency of CIC, but in this population, CIC with a 12 to 14 French is needed 4 to 6 times a day. And this is in patients that end up with a neurogenic lower urinary tract dysfunction. Less frequently causes the increase of the bladder storage volumes, and that increases the risk of UTI. If the UTIs persist and above is not possible, then a condom cap with external collection device or indwelling urethral Foley catheter or suprapubic may be necessary for that patient. So conclusions regarding this SCI patients, they have asymptomatic bacteriuria. They do. That's just what happens. And sometimes if there's no symptoms, there's no treatment. If UTIs persist after treatment, refer to a urologist to follow up for further bladder pathology. Annual monitoring of structure and function of the urinary tract is recommended, and that would be with urodynamics and such. CIC is a preferred method of emptying, which is good. Limited research to support the types of catheters. Again, get out your research brain here and let's do some research. No definitive evidence on the ideal method of cleaning or storage of those CICs. So again, get your research going. We need to do more research. So let's look at the common problems among children with spina bifida. Okay, one of the common problems is, of course, UTI. Another is vesico-urethral reflux. That's when the urine backs up from the bladder through the ureters to the kidneys. And this can cause high pressures, and then reflux can also cause kidney damage because the infection can spread to the bladder and the kidneys, from the bladder to the kidneys. Hydronephrosis is the swelling of the kidney from the backup of the urine. That can be serious. It can be caused by high bladder pressures as well. Incontinence, are they able to stay dry? Usually not. So we need to look at what we can do to keep them dry. And why do these problems occur? It's due to the nerve damage. The bladder and sphincter muscles may not work properly. The bladder is supposed to fill and store urine at low pressures and then empty every few hours. So both of these may be affected. They do have problems with filling and storage. They have problems with emptying sometimes. The bladder may not empty all the way. All of these things are common problems with these children with spina bifida. There's also 5%, I couldn't believe this, 5%, only 5% of children with spina bifida are unable to empty their bladders without help. Most children with spina bifida have a neurologic or a neurogenic bladder. So again, their goals is to help their kidneys keep working well, keep the child, help the child to empty the bladder, help them to stay dry. A lot of them do learn CIC. Ongoing assessment and monitoring, again, they're going to have urodynamic studies over and over and over. Voiding cystourethrograms, they're going to have renal bladder ultrasound, checking the creatinine and the BUN to make sure that they are not having any problems with their kidney function, and urinalysis and cultures. And renal scans is important as well. Infections and multiple sclerosis. This is very interesting. Infections are thought to be involved in MS pathogenesis and may influence the disease susceptibility in the clinical course and their clinical course. So acute relapses may be induced or exacerbated by infection, most commonly in the form of a respiratory infection or a UTI. So there seems to be an at-risk period of 2 weeks preceding and 5 weeks after the onset of infection, during which the risk of developing a disease relapse is increased, possibly due to enhanced immune activity induced by the infection. So other investigators found that the exacerbations of disease activity during the at-risk period were more likely and led to more severe and sustained relapses. So there is some connection there, and that's quite interesting about how it affects MS. Bladder dysfunction in MS. Detrusor hyperreflexia presents as urinary frequency, urgency, and incontinence, occurring in 50 to 90% of patients with MS. This is due to the inability to inhibit detrusor contractions, resulting in voiding and low bladder volume. Half of the patients with detrusor hyperreflexia develop detrusor sphincter dyssynergia, in which there is a failure of the urethral sphincter relaxation on detrusor contraction, resulting in high micturition pressures and symptoms of hesitancy, incomplete emptying, and intermittent stream and dysuria. Detrusor areflexia is most common due to sacral cord lesions, and it presents in approximately 20% of patients as urgency and urinary retention. Very interesting how this goes with progression of MS and bladder dysfunction. So with the progressive disease activity, bladder dysfunction tends to worsen in patients, often requiring pelvic floor exercises, intermittent catheterization, or an indwelling catheter. Due to the urinary status and or the use of catheters, these patients are increasingly susceptible to recurrent UTIs, which may, if left untreated, lead to systemic infection and sepsis. So infection-associated pyrexia may precipitate the neurological defect by altering the conduction properties of the demyelinated axons, and that is called UTOF phenomenon. Very interesting read, and there is reference in the back about that. Since recurrent UTIs have been proven to be associated with exacerbation of the disease activity, their appropriate management in MS patients is essential. So, and you know, before this lecture, I did not realize how much infection can really cause problems for these MS patients. So it's best to be prepared. Diagnosis UTI during assessment to presumed MS relapse. So patients who present for the assessment of acute relapse in MS, it's very important to do a urine dipstick to assess for presence of concurrent UTI. It may be why they have this exacerbation. The standard treatment for an acute disabling MS is high-dose corticosteroids, and typically either orally for 5 days or IV for 3 days. So the decision to send for a urinalysis and culture is based on the clinical judgment of the physician at the time of assessment. Where culture samples yield a single microbial species, patients are treated with antibiotics before commencing their steroid treatment. So current practice considers cultures yielding mixed growth as not pathological, but rather as contamination. So if there's one bacteria, then they're going to do it. If there's multiple, then they consider it to be not a problem. If they are asymptomatic for UTI, antibiotic therapy is withheld, waiting the results for the culture and sensitivity, of course. And if they're symptomatic, they're going to start them on antibiotics. Only once that their concurrent infection has been treated is the steroid therapy started. And you all know why that is. We don't want to interrupt that. All right, most children with cerebral palsy will develop total urinary control. That's interesting. However, they achieve urinary continence later in their age-adjusted. In other words, children without CP are going to, normal children, it's 3 to 5 years and 4 years, respectively, that they will attain daytime and nighttime continence. So it's just a little longer with these little guys. The median age for achieving urinary continence for CP patients with intellectual capacity as defined as the IQ over 65 and diplegia or hemiplegia is going to be 3 to 4 years. Children with low intellectual or an IQ less than 65, it's going to be from 10 to 13 years. Similar to neurologically normal children, children with CP will achieve daytime continence first prior to the nighttime continence. It's pretty interesting how they do, become completely bladder controlled by age 6. It's pretty good. One study involving patients with CP reported 23% require intermittent catheterization for retention, hydronephrosis, and refractory lower urinary tract symptoms. So children with CP are not found at risk for nephropathy. Okay, protection of the child's urinary tract. Very important that we protect it with CIC if we need to. Medications to prevent the treatment and treat infections, relax the bladder so that it can hold more urine, such as ditropan helps with that. Surgery to treat the reflux, to enlarge the bladder, to improve the sphincter function, or the suprapubic urostomy or a urostomy. Catheterization of CP patients, they often don't tolerate the catheterization, intermittent catheterization very well. Indwelling suprapubic catheter is recommended for them, and there's not a lot of information or studies on the complications with CAUTIs in this population. So again, there is your opportunity to do some much needed research. A lot of research out there. And can a UTI during pregnancy cause cerebral palsy? And the answer to that is yes. Yeah. So urinary tract infections and bacterial vaginosis, BV they call it, can cause a baby to be born prematurely and or have cerebral palsy. So if a UTI or BV is not promptly diagnosed and correctly treated in a pregnant woman, the infection can travel to the uterus and affect the baby. The infections are associated with an increased risk of many pregnancy-related complications as well. A few studies even show a connection between BV and second trimester miscarriages. That was interesting. When a pregnant woman is not properly tested for infections, such as a UTI or BV, and when standards of care for treating the conditions are not followed, it is negligence. If this negligence, of course, leads to injury in the baby, it's medical malpractice. So this is why most of the time when a pregnant lady goes in to see her physician, they end up doing just a disc, just make sure that they don't have an infection. So I found that quite interesting too. So again, the research is so important. You know, you can write articles for the journal. You can do anything with research in order to, number one, find out the answers we need to know, but also to increase your resume, your whole profession. So think about that research part, and you can look into Jay Watkins, look at that, and they will tell you where you can find out more information and get published. Thank you very much for listening. That's all I have for you today, and I'll hand it back to Brooke.
Great. Thank you so much, Kelly. What a wonderful, very informative presentation. A lot of valuable information on CAUTI. If you missed any portion of this morning's presentation, or if you'd like to download the slides and you haven't taken them from the handouts on the side, please visit shieldhealthcare.com/webinars. A recording of this webinar will be available by the end of the week. Kelly, could you please advance to the next slide? Oh, CE Contact Hour. I see you have it there. Okay, so just to reiterate, CE credits will be emailed to you within 5 to 7 days for everyone who has registered as a healthcare professional. If you don't receive your CE credit after 5 to 7 business days, just shoot us an email at marketing@shieldhealthcare.com, and we'll work with Capital Nursing Education, and we'll make sure that you get your certificate. Next slide, please. Okay, great. If you enjoyed today's webinar or found it informational, you can find more educational information on our community site. The website is geared towards healthcare professionals, patients, family members, and caregivers. We usually add anywhere from 15 to 30 fresh articles each month written by subject matter experts and a variety of contributors. So please stop by and look for any information that you need on our website at shieldhealthcare.com/community. That's shieldhealthcare.com/community. And for past and upcoming webinars, you can find them on shieldhealthcare.com/webinars. Next slide, please, Kelly. Okay, great. And also we have an array of free educational booklets on ostomy, wound, enteral nutrition, incontinence, and neurological care, as well as guides for aging safely at home. So if you'd like to receive or download a free copy, please go to shieldhealthcare.com/community where you can request one. The next slide, please. Okay, and if you need to reach out to us for any other reason, here is our contact information. We're available at marketing@shieldhealthcare.com, and there's Capital Nursing Education's email at capitalnursingeducation@gmail.com. At this point in time, we're going to take questions. We have a lot of questions that have come in. We'll power through as many as we can, and if we don't get to your question, we'll do our best to reach out to you individually to make sure that your question is answered. So Kelly, just first off, I'm going to run down the list. We've got a lot here for you. The first question that I have is, can you please clarify reperforming hand hygiene after using aseptic technique and before inserting the catheter per the slide that you mentioned early on in the presentation? Could you please clarify that?
No, that was what was in their guidelines. I questioned that myself, but again, taking off the gloves, performing your hand hygiene, and putting on more gloves. I think that's what is meant to happen there, and that is what the guidelines have said. So that was directly from the guidelines.
Okay, great, thank you. It seems that they're definitely making a point to clarify about the hand hygiene for sure. Next question, how can I prevent UTI using intermittent self-catheterizing when traveling using dirty public toilets?
I would definitely get the enclosed self-lubricated sterile device that you can use that it's self-contained. And I don't know the name of it. You could certainly look on Shield and find it. But It is self-contained, so nothing touches anything. You clean yourself, that's it. And when you push this in, the first part of the catheter going in is pushes against the meatus, but the inside part doesn't come out until last or until second. So it actually is already in the meatus before the actual catheter comes out into the meatus. It's very, very interesting. It is called a closed system, and the closed system is the best to use when traveling, I tell you, and then you just throw it away.
Okay, wonderful. Thank you. And just to add to that, I think the catheter you were referencing that we have on our website is JAW. That's a cath and bag. It's a closed system, but we do carry many different closed system catheters as well. Okay, next question. Let's see. This is the first I've heard of the use of condom cath bag being associated with CAUTI. What is the reference? And I believe you just mentioned that, but if you don't mind just clarifying a little bit, please.
I'm sorry, repeat that question.
This is the first I've heard of the use of condom caths being associated with CAUTI. Can you please clarify the reference on that?
You know, part of that is because sometimes they get constricted and sometimes they twist and then the urine goes back up into the bladder and it can cause distension, which then goes up into the kidneys. But mostly bacteria can go back in to the bladder through the when it is twisted or it's too full, nobody's emptying it or whatever. And I think that there are some catheters, some condom caths, I believe, that might, I'm not sure if we have any that have the antimicrobial. I'm not sure, but that would be something to invent. But that's how it happens, is just the urine going back up into the bladder.
Okay, wonderful. Thank you. Do you recommend wiping off the catheter drain after draining? And if so, what would you use to wipe it?
You know, that depends on your protocol in your hospital or wherever you are. I have seen different things. Some protocols say to use alcohol, an alcohol wipe to wipe it off. But from what I learned is if you don't touch it, you open it, drain it without touching anything and close it. That's the best thing you can do, because you can't always guarantee that somebody wiping it off with alcohol or anything else is actually not going to touch it themselves. So my recommendation, and hopefully it would be right for most facilities, is to simply open it without touching it at all. Drain it and close it back. And, you know, I could be wrong on that, but that's what I have seen in most of the facilities I've been in.
Wonderful, thank you. Another question here, what is the longest length of time that an internal or indwelling catheter can stay in a patient?
Oh, that's so dependent upon the patient. If the patient has incrustations, or if that catheter gets, you know, the open or the system is open somehow and contaminated, you have to change it. If they have a lot of, well, any type of obstruction, the incrustations is a huge thing. So it depends on the patient. I've seen catheters stay in 30 days. You know, I've seen catheters stay in longer. But again, it depends on what the urine looks like, depends on the patient's other comorbidities, and also depends on whether or not they have any blockage or any incrustation.
Great, thank you. There are some wonderful questions coming in. Another one, our doctors have been telling us that cranberry to prevent UTIs is not effective. Do you have any comments on this?
You know what, it's kind of like, I've heard it is and I've heard it isn't. It just changes the pH. That's what it does. And in doing so can prevent, I've heard that it can prevent the bacteria from lodging because it changes the pH of the bladder itself, you know, the actual lining. That's what I heard. Again, further research. I haven't heard that it's absolutely forbidden, but I'll tell you what, I would try it. I would definitely try it. Some people take cranberry pills, some people just drink cranberry juice, and that again depends on your other comorbidities. There's a lot of sugar, so you have to be careful with that. Vitamin C too, the same thing. I've heard it doesn't make any difference at all, And then I've heard it makes a huge difference. But again, I think it depends on the patient.
Okay, wonderful. Thank you. Quick question for you. Is it recommended for asymptomatic colonization to be isolated in a private room or any other kind of isolation?
No, I wouldn't think so. Asymptomatic colonization is just colonization. I don't see how that could affect anybody else around them.
Excellent. We're going to squeeze in one more question, and then we'll do our best to get back to everyone. Our facilities use a 16 French catheter kit. Do you recommend changing the standard catheter kit to a size 14 French?
I would. And again, depends on the patient. Some patients will need a 16, some will need a 14. It just depends. I had one lady a long time ago who I swear I could see completely through the meatus, all the way up into the bladder. I mean, it looked huge. And definitely she had to have a bigger one. But the rule of thumb is, and the guidelines say, use the smallest. I would have several there. Use the smallest that you possibly can for that patient.
Wonderful. Thank you. We'll go ahead and close this out here since we're just past 10 o'clock. But thank you again, Kelly Sparks, for a wonderful presentation and to Capital Nursing Education as well. Thank you, everyone, for your time on this Wednesday, and have a great rest of your day.
Okay. Thank you, Brooke.